So trial and error is not a good phrase to use, right? Patients do respond negatively to that, and you need to have the patient think positively, realistically positively. So what you do is you make the diagnosis, and you always tell the patient, I'm going to start with methotrexate. And the reason I'm going to start with methotrexate is it really works well in about a third of patients. You can read everything you want to about the side effects, but they really occur rarely. We'll talk about them. I'll tell you what to look for. I know what to look for. Chances of you having a major problem with the methotrexate is small, which is true. And if you don't respond fully to the methotrexate, many of the drugs that we use after respond better with methotrexate, so it's really worthwhile trying, and we'll know in 12 weeks whether it's working or not, and that's true. So then you have to examine the patient, which you should do as a physician anyway, before you start the methotrexate, and 12 weeks later, and did they respond? And if they didn't respond, then the question is, what do you do next? And that's where this question of trial and error comes up. And what I tell the patient is, we have multiple medications. Here's this, here's that. You take this way, take that way. They all seem to work the same. The side effect profile is relatively the same. Some differences, but relatively. What do you want to do? They tell me what they want to do. And then in the United States, the insurance company tells me what I'm going to do. And it's fine. That's fine. The insurance company does that, because what we know is that 80% of patients, new patients, no matter which drug I start them as the second drug, will respond. Right? 70-80%. They will respond. So that first time, they say, okay, you want this. The insurance company is going to pay for that, so it's cheaper, and the chances are going to be the same. Right? We'll try it. And that's 70-80%. They're happy as a lark. They're better, right? And they stay better. They really do stay better. Well, what about the other 20-30%? So now it's 20 or 30% of about 70%, so you're really about 15%. And you don't say it's going to be trial and error. I don't say that. So we're going to play the game. And they say, oh, what game are we going to play? The game is to find the drug that works. Well, how do you find that? Trial and error, right? But if you explain to them that we don't have the test, there may be certain characteristics. A patient may not have a positive rheumatoid factor. I'm not going to use rituximab, right? The patient has a demyelinating neuropathy. I am not going to use a TNF receptor, right? The patient may want to get pregnant, right, in a relatively short period of time. That patient is not going to be able to stay on methotrexate. I'm going to use a monotherapy. For the monotherapy, I may very well want to use a JAK first. I could use an IL-6. I could use one of those two, but not a TNF. So there may be differences. But, my father always used to say, it is what it is. You can't deal with it unless you deal with it. So that's what it is.